Morning, everyone. Thanks for joining us today. This is our last session with our Board of Governors preparation series hosted by Cal and our partners, San Diego Organization of Healthcare Leaders. Thank you for joining all these 4 weeks. And we want to wish you the best in your preparation as you move forward. In this week's session, we are going to cover the healthcare IT, technology and information management, and the quality and performance management domains. I think I'm trying to recall which one, but every few years, ACHE changes the weightage slightly, and I think healthcare IT got a little bit of change, maybe 1%, like the other domains. But overall, it's still a very critical domain along with quality and performance management. All right, let's move on. This is our Cal Advancement Committee that has been working tirelessly to help our members advance and get a fellowship. Thanks again for all the members. It's been a pleasure working with all of you to build this program. Michael, unfortunately, is not able to join us today. And this is our San Diego Organization of Healthcare Leaders, our partners we've been working with to offer this program. Thank you again. Nora?
Hi, morning, sorry. Okay, so updates and FAQs. Again, we're going to be sending out a SurveyMonkey after this series. And again, we want complete honesty, constructive criticism. We really do look forward to hearing how to improve this program. As marvelous as we think we are, there's always room for improvement. And again, remember that this is worth 8 continuing education credits, and you can self-report this on my ACHC section under your profile. And Rick, you're up. You're on mute.
Rick?
You're on mute, Rick.
Oh, that would help. Okay. That would help. I'll say that again. Yeah, this was we were taking this out because it was the other day. But reminder to keep your eyes open for events coming from Cal and Sol, both depending what kind of units you need, and certainly a lot of them are available by Zoom, particularly for the qualified education. So just keep your eyes open for that.
And interestingly enough, you could also register for other chapters presentations.
Yeah, I did one in Michigan that was really great. It was a Zoom meeting, and one of the best ones I've ever been to. So yeah, you're not limited to just where you're a member.
Let's go to the next slide. Next year, they're changing the requirements for the face-to-face and qualified education. Keep an eye out if you're for the next 2 months to register for any events and other chapters.
Okay, next slide. Okay, so we have 2 topics today, and the first one is going to be the IT section. And I feel a little strange introducing Sachin since you've been watching him for the last 4 weeks, but he's the head of practice operations at Valley Diabetes and Obesity. Within Cal, he's been very active, past chair of our communications committee, member of this committee. Within National ACHE, he's been on a couple committees. He received the Senior Executive Award from ACHE and the Regents Award and the Service Award. So he's been very active. And just point out that his business, the Valley Diabetes and Obesity, was the Small Business of the Year. So I will turn this over to Sachin.
Thank you, Rick. Thank you again for joining us today. All right. So my focus today is to kind of give you kind of an overview of the healthcare technology information management domain and also kind of walk through a few sample questions to help you kind of understand the topic and also how to answer some of the questions. And our healthcare IT has had a huge impact on where healthcare is currently. It has a lot of basis on all of the policies, regulations that we have put together over several decades since 1965, when we have Medicare came along. And I think the focus and the trends, if you look at overall, have been based on, you know, improving access to care, but also equally on making sure we have better outcomes, right? If you think about the studies we've done and the outcomes we have seen over the years, there's definitely a lot of improvement that we need to do. Unfortunately, considering the amount of healthcare spend we have from year to year, we are spending 18-19% of our GDP on healthcare, and to compare it with the other nations, we are pretty poor. You know, we are probably not even in the top 10, which is a shame. But also, it points to a lot of things that have to change, and there are a lot of things that have been happening over the years that actually are moving us towards that to help us get a better sense of the quality and also outcomes. You know, value-based care, Affordable Care Act, High-Tech Act, a lot of these things actually are helping us get there, but it's a long journey for us. And you all, as healthcare leaders, are part and parcel of actually making that impact, right? So part of understanding this healthcare IT is really to see where technology is playing a huge role in improving outcomes, in improving access to care, and also helping overall health systems to be more efficient operationally, right? So these are some of the topics that we're gonna cover. And I think the book that we are always recommending, the two books, obviously, the Well-Managed Healthcare Organization does a pretty good job in introducing that, but also we have another book focused on IT as well. More topics here, you know, processes in finance, operations, healthcare, all of these directly and indirectly impact the delivery of care, the quality of care, as well as the cost of care. So it's important to understand that technology and how we roll out technology and information systems and maintaining the access to that is pretty critical. And that's where the business continuity comes in, disaster planning, recovery. We have, you know, every day, not a day passes when we keep hearing about our challenges with cybersecurity, of ransomware, where there are a lot of challenges with the systems being hijacked, unfortunately. We also have patients getting their patient data pretty much being compromised on a daily basis. Not just on the retail sector. If you think about Target and Walmart announcing them, it's a bigger challenge when you have healthcare data being compromised, right? So, and I think the challenge is with every health system, however small it may be, as a smallest practice to a largest health system, understanding what those parameters are, what the regulations are you have to follow is critical. For a small practice like ours, even one HIPAA violation will cost us upwards of $30,000. And for a larger health systems, you know, I've seen companies paying upwards of $20-30 million because of ransomware just to get back into their operations. So understanding as healthcare leaders, the impacts of these is super critical. I don't have to say enough about healthcare analytics, but with the amount of data we have in healthcare, the impact of delivering care and quality, as well as evidence-based care, comes from understanding and using our healthcare data effectively. Healthcare analytics plays a huge role in it. And if you think about AI and what AI is going to play a huge role in terms of point of care, as well as just understanding the overall value of what we have data as an asset, is meaningfully captured with, you know, by healthcare analytics. And, you know, healthcare informatics is super critical. And there's a reason why these two domains are becoming a huge choice of a career path for a lot of our healthcare leaders, even healthcare executives, physicians as well. And I know a lot of physicians who have moved on to get another advanced fellowship in healthcare analytics or informatics. So definitely consider that as a great path because that's where we're headed. Awesome. All right, moving on. So let's go through the questions. And what I'd like to do is, definitely have all of you participate in our program here. Let us know your choices of what you think are the answers are. There's no right or wrong in terms of suggesting answers. We'll go through the choices so that you have a better sense of how to interpret that. Nora, if you could just point me where the participants are headed in terms of choices, then we'll get a sense of that. All right, the first question, a CMS program that requires provider to consult a qualified clinical decision support mechanism for the appropriateness of diagnostic imaging services is called. Do read a question. There are sometimes these questions are long, so try to kind of take your time to read
Words. Sorry, didn't mean to interrupt. Yeah, don't freak out. Lots of words.
Yeah.
Okay, I see a C popping up. Remember, channel your inner Rick. Go through the brain walk.
Yeah.
What a scary thought.
It's been successful though. We have proof.
All right, let's just go find the answer here so I can walk through. So one of the things that, like most of the healthcare stuff, we've passed a lot of laws and regulations and policies, and some of them jump out in terms of what they actually contain. Some of them are not so descriptive, but this is an example of choices that are kind of describing or mentioning the laws that are specifically questioning here. So the most important things here is ARRA, which is the option D, American Recovery and Reinvestment Act. It actually includes both the meaningful use as well as the HITECH Act in some form. And the funny thing is, they keep enhancing these laws as well in subsequent versions of it. So it's going to be, I think in this case, if you don't know what those, the scope of those laws are, it's going to be hard to kind of choose the right choice. But part of the thing that we have to remember is there are only a handful of the most important ones. So it's always good to document them so you know the scope of it.
So the key to, oh, I'm sorry.
Go ahead. Just go ahead.
So meaningful use is one of the terms in the flashcards. And the key to that is it's broad. It talks about certified electronic health records technology. This one was very specific. So that's the key.
Yeah. So meaningful use, I've seen that a lot of you may have chosen this. It's basically the mandate for that is to enable providers and health systems to encourage using EHRs meaningfully in terms of driving, capturing a lot of this documentation, prescriptions, etc. The American Recovery and Reinvestment Act, as I said, is a broad act that covers meaningful use and EHRs, but also includes other aspects of it as well. The question we have to always remember is they're very specifically asking about one action, which is part of these laws. So in this case, the Protecting Access to Medicare Act of 2014 actually is a broad, within the scope of that, there are a few things that have been added. One is they have updated the use of the clinical reforms in terms of labs, how insurances charge for lab services, and that affects Medicare payments as well. But key to that program was also mandating what's called a clinical decision support mechanism as a tool that physicians have to look up to recommend certain diagnostic images to be used. I think the goal there was to restrict the unnecessary order of labs and other services that fall into that category. And it's very specific to this act. So unfortunately, unless you know the scope of that, it's going to be hard to pick the choice B. But just to give you an idea, there are like 6 or 7 focus areas of that act. And one of them is CDSM, which is mandating the CMS program mandating that providers use this tool to actually order the imaging services.
And the definitions for A and D are also in the flashcards.
Flashcards are a great tool, especially to refresh some of these acts and definitions. All right, let's move on. Nora, if you do have questions, definitely pause me so we can address that as well. COVID-19 pandemic played a significant role in the expansion of telehealth with 1135 waiver by So this is another specific tool that CMS has provided. Again, I think as healthcare leaders, you may have come across the waiver itself, but 1135 is a specific waiver that allows health systems and states to really introduce innovations in the payments or delivery of care, demonstration projects. It's like a one-off, like a small project. They have definitely gives you flexibility to try a few things.
Okay, we've got some Ds coming up. So far, Ds are ruling.
B as in what?
The Ds are winning.
Oh, Ds. Okay. All right. All right. Let's do this. Okay. So if you look through the options, obviously it's about telehealth, right? And I think if you recall those 2 years, we have seen the huge impact COVID had in terms of just having patients visit clinics or hospitals. So telehealth in general has always been there for several years. Unfortunately, the adoption of telehealth has been a huge challenge because there were so many restrictions around it. That, for example, you have to be in a certain rural area, you have to be a certain health system, like a rural health clinic. You need to be able to have the nearest location was, I don't know, 2 hours away or something like that. Only then you're allowed to even offer that service. And also the technology was also a huge issue because it required certain infrastructure to be in place at the originating site to be able to do that. So I think the best thing that happened during COVID was really CMS relaxing this requirement. And the 1135 waiver was the tool that they used to say, here we go, entire country, every practice is now allowed to see patients over telehealth without these restrictions. So that's really the purpose of that. So if you look through the options, again, going back to our suggestion, always look at the broadest application of this. Options A, B, and C are kind of limited in some, they're not the broadest, but if you look at D, the Medicare paying for office, hospital, other visits across the country, it gives you the broadest aspect to it. It includes both audio, visual. It doesn't have to be not only at the place of residence. Even we were able to call patients at their SNFs, physical therapy sessions, any of those locations. So that's kind of way to look at how to answer this solution. And I think as of May of this year, obviously they are starting to roll back some of these flexibilities you had in during this waiver of telehealth. Well, personally, we are seeing in our practice right now where the telehealth is restricted that it has to be audiovisual only. You cannot do audio only. And they are reducing the reimbursement if we do audio, for example. And if you're doing certain things, they want us to get the patient in person rather than do them over the telehealth. All right, moving on. Why is it important for the ID strategy to align with the organization's goals and objectives? One thing that we have seen over the years is IT has definitely gained a lot more relevance in a corporate strategy. It's no longer just a cost center that you have to allocate just a budget and let them figure out the project implementations, etc. Being the role it is that now we have the IT playing like a CXO at the C-suite level. We have an IT steering committees, we have CIOs, we have even chief informatics officers, several other key roles because of the role IT plays.
We've got lots of Bs coming out.
Good to know. All right. So I think we are on the right track. I think everybody gets it. And if you look at the options here, you can quickly eliminate options that actually don't make sense, right? With respect to the question. For example, to increase Medicare payments, option A, it has nothing to do with IT, right? So it's easier for us to eliminate those choices like that. But if you look at options C and D, C, it's not just a CEO as with the table at the position at the table. Obviously, the CIOs and CTOs actually have a lot more say because they have been delegated the responsibility to really manage it. So that's really not the essence of getting that importance there. But remember the question, why is it important for the strategy to align with the organization's goals? Because at the end of the day, the information technology, the implementation, the directions is all tied to where the health system wants to go as a goal, as a strategy. If the focus is now to improve our patient outcomes, everything that we do down into the technology side has to reflect that. And that's why they have a table, that's part of the table, right? Option D is really, yes, that's one of the aspects of giving a seat at the executive committee, but overall, option B gives you the best scope of why this is so critical to improve access to data for management, providers, and consumers, because data is what drives patient outcomes, both at the management level, providers level, and consumers. Basically, having so much of, we have several new acts which are giving more control over their own data. Consumers want their data. They are paying so much out of their pockets. They are the ones deciding. Now there's so much of transparency in terms of pricing. That's all because of the demands of consumers have. So that's why it goes back to my original comment. This data is the key asset for healthcare IT, and everything that we are doing in terms of planning, execution, and even measuring our outcomes comes through that data. So at the end of the day, our strategy has to be around making sure this access to data is planned and executed well. Moving on. What competencies do not matter in selecting a CIO? I think this is an easier giveaway.
Got C. We've got a B, several C's.
Great. So if you think about it, right, considering that we are looking at our broad scope of healthcare IT, we are not as far ahead as like finance or other industries where they have leveraged technology so efficiently, but we're getting there. But for the same reason, the issues that have impacted these other industries are now common, whether it's a security, cybersecurity, or the amount of data we have, which means infrastructure management, etc. Technology. Now we spend millions of dollars in getting epics and other implementations. So we are seeing a lot of these healthcare systems bringing folks from outside into healthcare. So knowledge of healthcare organization delivery is a must-have in several cases, but it cannot be the rule that you're gonna find the best of those in a healthcare industry itself. So it is desirable, but depending on the role or where you're coming into the organization, it may not be needed. If you've done this building of infrastructure or cybersecurity or even networking in other industries, we want to bring those because it's the same technology that needs to apply. So B is definitely not the requirement, but prior management experience, again, from a leadership point of view, it is always desirable. It's maybe a requirement depending on what level you're coming in. Same thing with finance and budgeting skills. But the thing that we really don't want to see is, relationships with board members kind of playing a role, right? So it kind of makes sense if you think that way. All right. When introducing a new information technology system to a healthcare organization, resistance can be effectively addressed by
Okay, we've got C, lots of C's. Yep, more C's.
All right. I think we're on the right track here. And just to give you a quick context in terms of information technology and production of a system into a healthcare organization, this applies to all industries, not just healthcare organization. Whenever you're introducing a technology, if you look at overall the success of these projects, the biggest challenge for a lot of healthcare organizations is how successfully it has been adopted, embraced, and implemented. So you actually see the value of it, right? The challenge is that if you don't plan it well, and from a project management point of view and from a sponsorship point of view, you do not see that successfully. There's a huge impetus on making sure that we are building. It's not that we should build a system and then invite our users, physicians, pharmacists to start using it. And that's the wrong way to look at it, right? Because that's why a lot of times there's a resistance in terms of using it. So if you look at options A, B, and D, these are the things that actually impact how effective the system has been implemented as well as used. The biggest critical component of introducing any health system is to make sure that you're engaging the right users, whether it's pharmacists, whether it's your nurses, whether your physicians who are effectively going to use the system. They have to be part of it from the beginning, not only in driving the requirements, understanding the gaps, the usability of it. I don't want to be able to use this in this setting, and I'm going to use the same application when I'm on the road. All of these requirements, you cannot have a consultant or a steering committee or somebody just coming up with those requirements or just randomly choosing a vendor to implement, right? So having those systems being part of it from the beginning helps you, because they are going to be giving that key input to the system, and along the way helping you choose the right vendor that meets those needs, helping you be a pilot user and giving you feedback, what's working and what's not working, creating or taking ownership and documenting those flows, and also taking ownership as a manager, turning around, talking to your staff and making sure they understand why you're introducing that system. All of these along the way is what helps you successfully roll out and make sure that that's being used along the way. And the success of the project comes on how effective it's being used end of the. So that's why the C is the right option here. All right, moving on. The best way to facilitate information system integration within a healthcare organization is to
We have D. Seen D's, lots of D's.
Right. I'll just give a quick context for this one. Systems integration comes into the play when you have different applications being used to capture patient data, patient interactions, prescriptions, patient registrations, medical records. Unfortunately, that's the way we have built our systems. It's always a balance in terms of finding one giant software like Epic that does all of our stuff versus starting to pick the best of the breed for doing certain things, whether it's prescription management, whether it's decision support systems, etc. But invariably, software is built in different contexts, right? A dental company, a dental services company that uses a different software completely compared to our health system. So in the challenge that we have is that we have data that is spread out because applications are spread out. They have their own data systems and they have their own patient data, and we have departments wanting to use that data to make decisions based on what the patient needs. And the problem with that is that if the application is not able to be integrated with each other, it's going to be hard for us. So you have to do a lot of manual export of data, right? So the choices here are trying to explain to you what's the best way to really allow us to use data from each other and able to talk to each other, right? And option C, for example, use computer software from only one vendor, and the example I was giving you was Epic, is going to be so expensive for a lot of health systems, right? So just looking at that is going to be impractical. It may not be suitable for a SNF versus a small practice versus a big health system like Kaiser, right? So that's why we have 200 plus EHRs, because there's one for every group or every need. So that's kind of how you can eliminate option C. Now, I want to talk a little bit about what data definitions mean and data structures mean. It may sound a lot of computer verbiage there, terminology, but at the end of the day, if two programs have to talk to each other, they need to have a common language, like how you and I are talking using English as a common language. And luckily, over the years, computer systems and industry, as they evolved, they realized that for applications to talk to each other, we need to have that standard way of talking to each other. And that's really what the data definition is. So if I say date of birth is always, 2 digits for month, 2 digits for year, day, and 4 digits for year, that's a standard definition we have defined. We still have some EHRs that capture 2 digits for the year. Now, when you have applications assuming and expecting a 4-digit year and another EHR always sending you 2 digits, that's where you have that conflict, right? But by having the standardized definitions, we have more opportunity for applications to talk to each other intelligently so that you have more user flows that can be created that are more user-friendly. So that kind of helps you understand the concept of the system integration there. Great job there. Next, knowledge management is defined as, and this is a concept that applies not just to healthcare, for every industry that we have, because data and knowledge is what's powers every operation, every business transaction that we do.
Okay, we've got A and D. A couple more D's. Some more D. Yeah, got some D's coming through.
All right. It's a good question. I think it will helpful to go over these four options here. I've often seen that we get confused with them. So the four options we have actually a way are defining certain terminologies here. And let's go from the bottom, option D. The planning, organizing, directing, and controlling of resources to accomplish goals and objectives. This is actually the definition of project management. It is allowing us to define an initiative and how you plan, organize, direct, and allocate resources and manage resources, and also, controlling the budgets to achieve these goals. So that's the definition of project management. Option C, a movement to explicitly use the current best available scientific evidence for managerial decision making. This is the definition for evidence-based management, evidence-based care, evidence-based delivery of services. And this is a goal that we have in healthcare, and every system, whether it's a clinical decision-making system or other solution that we have built, the goal is for us to really base our decisions on scientific evidence. Option B, the transfer of structured information between two computer systems. This is a term, the definition of EDI, which is electronic data interchange, which helps us to exchange information like in a typical simple example would be how we are able to submit our claims to our insurances, and we all are relying on systems to send this information to standard forms, and how the recipient is able to understand the claim you sent, the services you provided, etc., using a standard definition. And this is a terminology for EDI. Option A is a practice of explicitly and deliberately building, renewing, and applying relevant intellectual assets to maximize organization effectiveness. So as I mentioned early on, data is the most valuable asset that we have in healthcare. Now, if you take data and broaden it out in terms of information and intelligence and processes that we all have within healthcare, whether it's claims management or clinical operations or evidence-based protocols around disease management, all of these have knowledge behind them that practitioners use, that staff uses, that medical office staff uses, etc. So knowledge management is that broad category of how healthcare collects that information, organizes them, and specific to each department, how they are actually distributing them so they actually can do their jobs. And so in that regard, A is the definition of knowledge management. And there are different ways each company does it, each health system does it, and depending on the scope of what services they provide. For example, a physical therapy services company would be focused on those aspects specific to their delivery of care. But there are some common things like how would they bill and how would they work with certain payers that may be common to every service provider. But overall, the knowledge management as a concept is really about how that information process and is collected, how we need to keep updating it. For example, every year we change our CPT codes to bill. They keep dropping some, adding some new ones, and we need to have that process to somebody within the company to be able to be on top of it, and then create it and also update all of our relevant departments so they actually can code our interactions correctly. That's just one example. But I think knowledge management is in that regard a broad category that helps health systems to be on top of.
I appreciate Rick's explanation of why he chose between A and D. As I went down the rabbit hole, and I also thought D was the correct answer.
Great. All right. Which of the following is a reason that system support of outcomes data collection and analysis can be very complex? I think some of the previous questions, I brought up this context about data being spread out all over, systems integration. All of these kind of point to the same challenge that we're trying to address.
Got a couple of A's. We've got a D. Got another D.
All right. I think I think A and D are pretty close in terms of the challenge that we are seeing, right? So if you look at option D, variation exists between open system architecture, interface engines, and multimedia data entry options. And it goes back to our previous comments, right? Which is that we have multiple health system, applications, different data repositories, data being stored in different ways. And that always is a challenge. And how do you connect them? How do you get the data out of each of them? The difference between option A and D is the D talks about the challenge at the highest level, as in when we have so many of a variety of applications. How can you pull these together to actually get the data? What option A is talking about is the required data typically resides in multiple information systems. So in a way, A is encapsulated into D, right? Now, go back to the question itself. Which of the following is this reason that system support of outcomes data collection? So by solving the data definitions, for example, option A, we are able to solve the solution of challenge that we have in option D. In this case, option A is the most suitable because that's a fundamental issue that we have, which is the data itself being residing in multiple systems. Once we have a standard definition of how data is represented across all these systems, there is enough APIs and interfaces that have been defined that actually help you get the data together. So, for example, in our health systems, we have what's called CDA, Clinical Document Architecture. We have something called Health System 7, HL7 interface. These are standards that have been in existence for a few years now, and that helps us to actually bring the data together pretty easily in any applications. If you have a lab result from Quest, any EHR is able to open that data because Quest submits or gives you the data in a simple format that everybody understands. So if I pick a particular data value within the lab, for example, a high cholesterol value, it's the same tag that everybody understands. Everybody uses the same thing, right? So those standards exist. I think if we have each data element mapped correctly, then it becomes easier for us to do all of this mapping. The problem is that because data is all over the place, it's harder to bring all of them together and figure out to understand what is the outcome, what was the patient outcomes are. And that's where the biggest challenge is. I hope that kind of clarifies that. I think option B is talking about something different in terms of financial information systems. There is a inconsistent medical terminology. There's always going to be inconsistency because we have so much of data coming in. But there has been over the years several terminologies that have actually been standardized. For example, ICDs and CPT codes for billing. We also have SNOMED terminology for interpreting all of our procedures that we do within the health system. So there's definitely a growing number of these medical terminologies being standardized. So it's not inconsistent, definitely. So in that regard, C is not the right answer. Membership of the ID steering committee should comprise of.
Got a B. B's, B's. Got an A.
I think we're on the right track here. So the purpose of the ID steering committee is to really help the management to prioritize, choose, create infrastructure in terms of making sure that we are executing in the right way. And I think the goal is also to make sure that it is the most inclusive. And why we need to be inclusive, right? We talked about early on about the success of a lot of these health IT projects really depends on making sure you're including the right stakeholders early on and all through the project. And that helps them be more committed to the project, but also have a stake in the success of the project. And if you think about that definition, B is the most inclusive, and A, C, D are really bringing or limiting that participation. And you will not get the representation or the perspectives of the key other stakeholders, whether it's major users, whether it's physicians who actually are ending up using the system. So we're losing that perspective, and that's why B is the most inclusive. And you typically see this question asked in different ways, but always think about it's not, yes, the purse matters, the mandate matters, the CEO's blessing it matters, but at the end of the day, this IT steering committee is comprised of the right people, so they actually have this their input into it all along. Selection of information system in a healthcare organization should begin with
Okay, we've got a C, some C's.
right.
C.
Let's see where we are with this. So it looks like we're pretty much on target there. So the scope of introducing any healthcare information system really is to, again, this kind of in a way repetition, right, of where our priorities exist. It has to be matching your corporation's strategy of where you want to head. What's your priority for the year in terms of patient outcomes, in terms of overall introduction of new services, whatever that goal is. And that's when these are the ones that will form the basis for us to select the appropriate information system. And if you look at options A, B, where we are talking doing it, you're maybe jumping ahead in a way, right? You're not going to ask vendors to kind of help you define what the scope of available technology, but in a way you're asking them, well, what is the strategy should be, right? That's why it's important for us to make sure that it's like putting the cart before the horse. Understanding that is important. The consultants do help, but there are consultants to even help you drive the strategy sessions, but at the end of the day, you need to really have your strategy in place and your goals and how you're going to move forward with it, and then bring on your health systems integration plan. That's why C is the most appropriate. Now D obviously again is jumping far ahead, in your implementation plan. That's when you actually, once you decide what the solution looks like, what are the core services that it needs to provide, that's when you can decide, what is the available hardware and software is.
Is it fair to say that in all these words, finding that word plan helps clue in on that response?
It does, but I would probably think about more strategic objectives and goals as as bigger emphasis. Make sure that that is meeting those goals as the first step.
Okay.
There's a planning aspect, if you think about it, right? Every initiative, every part of the execution, there's a planning aspect to it. I do agree, especially in health system implementations, planning is the key component and one of the most earliest aspects of our execution. But we also have to look at the key strategic objectives as what's driving that.
Okay. Thank you.
All right. In the IT system development life cycle, which is the most important step?
Got B, E, the D, B, we've got an A, D.
All right. Let me give you the answer. So one thing, if you want to remember about healthcare IT implementations or project development within healthcare IT is what's the system development lifecycle, or they also use software development lifecycle, SDLC. Is a term that basically what is the life cycle of actually either building, buying, implementing, any of those terms, right? What is the overall scope of it? And typically there's a phased approach to it. And these four kind of fall into that different phases of that of this development life cycle. And analysis, design, the terms may be a little different for acquisition and implementation, but at the end, you basically have to understand what are the 4 or 5 phases of this life cycle. And one of the most important phases of this is analysis, systems analysis. In systems analysis, what you're doing is you're trying to understand what your current system is, what your current process is. It could be a manual process, but it helps you understand the overall process that you have. What are the gaps that you have? What are the things that you want to change? And how are you going to figure in optimizing some of these steps that you have within your system? Right? That's why that analysis is so key, because it helps you kind of then define the care gaps or the gaps that you want to implement to make this a better system or to replace this completely, right? If your goal is A and this only does 20% of reaching that goal A, you're finding that 80% is the gap. You're identifying what that 80% looks like. And if it's not worth building that 80%, you're going to buy a system that does that 80%, right? So you can't go out and design a system, buy a system, or even roll out the system without understanding what that 80% of the gap that you have, or 80% of the efficiency that you want to build it, right? That's why analysis becomes such a key component of SDLC and is the first step of any of the IT project implementations. Now, the system acquisition can be interpreted in a different way, but it could be buying the software. It could be buying, if you have like a cloud-based system, licensing that or purchasing that. Again, this would come along the way once you go past the analysis and actually designing the system. How would each of these departments interact with each other? How do the user systems work? And then you go on actually finding the right vendor to either build it or to actually buy it. And that's where the acquisition comes. The implementation is really taking that last step, saying, okay, I'm ready to execute this, whether it's bringing Epic into the system or you're customizing the templates and the workflows on an existing EHR that's on the cloud and rolling it out, training the staff on how to use it. That all of that comes into the implementation part. So hopefully you've seen that phased approach, and there's variations of these questions again. What is the correct order or sequence of a software or a system life cycle? And they will say, A, comma, B, comma, C, comma, D, or B, C, A, D, and just kind of getting to for you to understand how to really sequence that multiple phases of this life cycle. hope that that kind of gives you a perspective of that. All right, I think, was that the last question, I think?
That is the last question, so.
All right. Well, thank you so much for being part of this. Unfortunately, I have to step out for the rest of the session, but please do reach out to us for any questions. We will be sending out this presentation in the next couple of days.
Thank you, Sachin.
Thanks, Sachin. Let's move on to the next question there, or next slide. Nora, can we move on to the next slide?
I don't have control of the slide deck, sorry.
Who does? Did Sachin just leave without it?
I'm still here. I did
Okay.
make you both co-hosts. You're not able to manage it?
Will that let us
You can't leave, Sachin. Sorry.
yeah,
Let me see if I can make you the host. Hold on.
yeah, I am the host, but sorry, it's not letting me control the slide deck, but let me open up my one instead. Isn't technology really fun?
I know. Speaking of technology.
There we go. Okay. I'm going to see. Okay, I'm going to share my screen now instead. Get this to work.
There we go. So we should be on slide 20.
Here we go. Here we are. There's Navi. Okay. I guess I've got control of the slides now. Okay, so let me introduce Navi Outwall. Navi is actually one of my graduates, which makes me really proud to see her doing all these things. She's a managerial consultant at Kaiser Permanente down in the South Bay. This year, she started teaching the quality class at Cal State Chico. She's been very active in Cal, currently serving as the board secretary, and she recently received the Early Careerist Award. So I will turn this over to Navi.
Thank you, Rick. Good morning, everyone. I will take the remaining about 20 minutes or so, Rick, is that right? To cover the quality section of the exam. So I know that the Board of Governors exam prep committee has probably sent out some recordings and materials to you all, but just the next couple of slides, much like Sachin did, are covering a brief outline of all of the information that will be covered in the exam. But before I dive into that, I do want to recommend one item, which is a textbook that I use in the course. So I'll put that in the chat. Anyone who would like to spend a little bit more time in the quality section, I highly recommend the SPATH textbook that I just put in the chat. It covers pretty much all of the knowledge criterias to the dot, and much of the information. It does a really beautiful job of outlining much of the information that you'll need for the exam. So that's in the chat. I'll just start with the very first knowledge area, which is benchmarking. So when I think about benchmarking, I'm really looking at it from the perspective of what are the ways that we can assess our performance? What are the tools, the techniques that could be needed? But also, what are we doing to compare our performance? I would recommend, I know Stan has recommended similarly in previous sessions, looking at the standards that CMS puts out and looking at how those standards are comprised and how to compare your individual organization's performance against those standards. When it comes to medical staff review, that's part of conditions of participation for the Joint Commission to have an organized medical staff. The basis here when it comes to quality is really understanding that your board is not going to have all of the information to assess the performance of your medical staff. So there really needs to be someone there who can advise the board on the performance of physicians and advocate for high quality of care. What the next section is around risk assessment. So when it comes to risk assessment, I'm really looking at it from the perspective of how do we protect the organization from potential financial losses that would be there because of some exposed risk. And again, the textbook that I put in the chat does a really great job of outlining that. Managerial performance and process improvement tools. When I think about that, I'm really thinking about Six Sigma and Lean. Lean looks to really reduce waste in a process, and it classifies waste into 8 different types. Six Sigma takes a more of a statistical approach, and it looks to improve a process by reducing variation. Both of them are really looking to ensure that you have the best processes as possible to really get a competitive advantage and to develop a better product. The next section is, oh, sorry, Rick, one more back, utilization review and case management. For here, I'll mention that, again, advocating for the book in the chat, that does a really great job of highlighting what are the utilization management, resource utilization components for both a hospital as well as a health plan, and what are the requirements for both. Just looking over at my notes, nothing else to highlight there. So Rick, we can go on to the next section. Clinical performance and process improvement tools and techniques, clinical pathways, evidence-based medicine, population health, pay for performance. Those get covered really well in the textbook, but in addition to those, I'll also talk a little bit about some of the other tools that didn't get highlighted around process improvement. So you get a lot of the technical tools like the fishbone diagram, or root cause analysis, the 5 whys, and so on and so forth. So being just a little familiar with where might those rules be helpful and how might they help you to understand a problem and then to create a plan for addressing the problem. Knowledge of quality and performance measurement tools, the HCAP survey, Net Promoter Scores. The HCAP survey in particular is for the hospital. That's a patient experience survey that goes out to anyone who's over the age of 18 and has had 1 night of inpatient stay. And the results of that are available through the CMS Compare website. So it's a way for consumers to shop around to see where they can get the best service for their particular condition or need. So it's important for organizations to have great scores on those results, but more importantly, for organizations to prepare their staff as well as the patient to know how to address the questions on the survey. In tools for improving patient safety, there's a great section in the textbook that covers, or a whole chapter in the textbook that covers patient safety. Patient safety is one of the 6 dimensions of healthcare quality. It really became important back in 2003 when AHRQ made it a priority and started to collect data and reported that data in 2005 around things like adverse drug use, bloodstream infections, pressure ulcers. Most hospitals have a safety program for addressing things like emergency preparedness, risk management, and other aspects. So again, that chapter does a great job of providing comprehensive overview when it comes to patient safety. Recognition of quality as a strategic initiative. distinct from operations and how it impacts operations, staffing, and financial decisions. When I think about quality as a strategic initiative, there's a few things that come to mind. One of which is that we're in a very competitive environment where consumers have a lot of information available to them. They can shop around for plans, they can shop around for services. So quality becomes the core of how you're able to distinguish yourself as an organization and your services as an organization. But the importance of quality also shows up in other ways. I think a lot of organizations aim for things like the Baldrige National Quality Program or the Baldrige Award and other aspects. But quality, in my sort of biased opinions of teaching the course, is really how you gain market share. So because there's so much information available to the consumer and it's very competitive, healthcare costs are rising, consumers are going to tout to see what they're going to shop around to see where they can get the best quality service and product. And it's how, as an organization, you can really distinguish yourself. Rick, I think we can start on the questions. Okay. And Nora, I understand that you'll share the responses that are coming through. Okay, perfect. So critical paths are important because and I'll try to monitor the chat as well.
Remember, put on your Rick Brainwalk hat here.
Seeing the first response C come through. B.
Get some B's here.
Okay, awesome. So it looks like it's B's, and Nora, do we get to know if that's the right one? Oh,
That'd be Rick.
B, Rick. Yep, B is the right response. So thinking through this really briefly, when I look at the answer A, provide support in malpractice, they can, but is that their primary focus? Delineate best practice protocols. So critical paths are really important because they're really a tool to turn clinical guidelines into clinical processes. So, there's a lot of research that happens in medicine. How do we make sure that we make it part of our internal protocols or our internal processes? Increase patient throughput. That doesn't necessarily jive and ring a bell for me personally, because patient throughput is a lot about efficiencies and how do we move patients efficiently through our systems. Reduce resource use. Yes, they can, because if they are highlighting what's the appropriate protocol for providing care, but I'm not sure if it's the most important or the item to highlight here. All right, next question. Which characteristic of a high-risk process would tend to increase the risk of a process failure? Okay. C.
Oh, we've got C's. Yep. C.
And Rick? Absolutely. So variability is how you expose your process to more risk. So anytime you're looking to, if there is, this is one of those questions, if I'm putting on my Rick hat, this is one of those questions where I have to think about the response in an opposite way that I would normally. So the way I reduce, the way I make a process more efficient, more leaner, more reliable is by reducing variability. So again, just looking at it from, yep, and Rick mentioned it.
See, you think alike.
He's drilled it into my head.
Yes.
And the next question, please.
I wanted to make the point about reading the question carefully.
Mhm.
Yes.
In conducting a risk assessment, what would be the first action to take? D.
Okay, we've got an A.
P, A. Another A.
Mhm.
Maybe we'll just wait for one more to come through and then share the response.
This links really well to to question number 2.
A. So the first step in really any quality improvement work is really understanding what you're dealing with. And this is like what I preach to all of the students in the classes. You can't fix a problem if you don't know what the problem is. So it's really understanding the current state before you can address what you're going to fix, what could fail, what you need to improve on. You know, all of the other steps are almost anything you would do in fixing a problem after you know what the problem is. Anything to add there, Nora or Rick, before we go on?
Again, risk analysis is in the flashcards.
Awesome. Next question. In designing a risk management program for your organization, what approach would have the most impact on reducing risk? Seeing a B come through. A, B. A. Rick, do we want to reveal the answer? B. So the important piece in this question is would have the most impact on reducing risk. To me, that translates into prevention. So if I'm trying to prevent anything that is of risk from happening, what would I want to do as an organization up front? So when I look at option number A, developing a reporting system for medical errors and injuries to staff and visitors, that's almost after the fact. So whatever is of risk has happened, and now we're capturing information afterwards. C, use task force to address key JCO standards that apply to risk management. Yes, but is that really based on your organization? And is that really doing anything to reduce the risk and increase safety for your organization? For this one, I was really torn between B and D. I'm going to be honest. Educate staff on potential risk and patient safety practices. You know, if I was taking this exam and I had this question come up, I would contemplate between B and D. But again, I think Rick is highlighting in designing a risk management program is what puts it over the edge. So you know, in this case, it's like going through the process of elimination and then being left with a couple of responses that you can pick from.
Navi, the reason I would have gone with B rather than D is, I mean, they're both correct, but the question has the word most impact. So, educating people will have an impact, but, you don't necessarily know if you're concentrating on the most high-risk areas. When you do the assessment, you may identify the need for education on potential risks, but you have to do the assessment first. So that's where I think it fits best with most.
Yeah, and B put in the chat that education is least impactful. Again, being tactical and bringing in your own experience can be really helpful. And I think for me, and looking at this question, it really is about process of elimination and going through and eliminating options for responses that that are not going to work.
On
Okay.
this note, we're really running out of time and probably only have time for maybe a couple more questions.
Sure, I'll try to speed through the rest. What action should you take to ensure all critical activities associated with care of a patient are being carried out in the right sequence in your organization?
Got D.
D,
Got a
B. Okay, Rick, I think for sake of time, B, develop clinical pathways. So again, for this question in particular, it's the right sequence of steps that are required to carry out the clinical practices. That goes back to the definition of clinical pathway. So it's in the definition of the phrase itself. All right, Rick, next question. Your medical staff on the general medicine unit has been complaining about the delays in the administration of medications. You studied the processing times on the other units and indeed find that the general medical unit times are considerably longer. What would be your first step to take? So this sounds like a process improvement initiative. D. D.
Got D's.
D's. Okay, great. So I think D might be the answer then. Perfect. Implement best practices from other units. Units are unique to each other, to them individually. So carrying over best practices can be an effective technique, but not in every single case. And we're looking at a specific problem related to the general unit. Having the manager from the highest performing unit assist the general medical unit in its improvement efforts, sure, that can be helpful, but again, is that the right response? Establish benchmarks for processing times across the organization, but it doesn't address the issue. Organize a process improvement team on the general medical unit. This is one of the core principles of doing process improvement work in healthcare, is that you want to make sure that the team is representative of where you're addressing the issue. Oftentimes you want to make sure, but almost all the time actually, you want to make sure that you have frontline staff who are represented in your improvement project team, who can share more details about the problem that you're dealing with, and can help you understand the problem and address and implement changes to address the problem.
This is one of the best, sorry to interrupt. This is one of the best examples of look at those key phrases in a lot of words.
Mm-hmm.
First step and general medicine unit. A lot of words in there, but remember to look at those key concepts in there. Sorry.
No worries. What tool is most appropriate in identifying priorities for action?
This is when you need to know the definition of these, and I always forget.
C.
That's C. Mm-hmm.
Rick, sounds like it's C. C, perfect. This is the 80-20 rule. I always think of Pareto charts, 80-20. That gives you an area of focus, what to address first. And some of the other options don't really do that visually for you. What approach best ensures loyalty return visits by patients in your organization, or to your organization, excuse me?
I always forget the answer to this one too. Okay, we've
B,
got B's, E,
C. Rick? B. Yeah, again, I think this is, when I'm reading this question, I am thinking of active steps that my organization can do that is ensuring return visits while the patient is with us. So the other ones, patient satisfaction surveys, sure, that gives me information, but that doesn't do anything to actively ensure that patients would return. An effective complaint resolution process, they've already complained. Sure, they might return, but that's, you're looking at a proportion of the total population who did visit your organization. This proportion is those that have complained. Customer service training, sure, but again, that doesn't ensure that patients are going to return. And who is the customer service training for? Patient engagement is really what stood up for me, in that it's taking active steps to ensure that patients have a good service and they're able to return.
Remember the broadest answer in this case. Sorry, I think we need to go ahead and stop, and I so apologize because I know there's so many more important questions. We're going to be presenting. Okay, so you need to channel your inner Navi when you start going through these questions. Her approach is fabulous. You can tell she and Rick know each other. On the closing comments, we'll be sending all this out. It's just a reiteration of what we've been talking about all before. Be sure to look at the questions, understand the key concepts. There's no substitution. This course was not intended to substitute your studying. We've shared the resources that ACHE offers. We've presented experts in the field. You yourselves are some of the best experts in the field. One of the closing comments is, please set up study groups. I'm going to be sending an email out. I will be sending an email out with everybody's email addresses who is willing to participate in being contacted to be part of study groups. If you're not interested in doing that, I'm going to give you my email address. Contact me, let me know. No, I don't want to be on that list. And again, when you do pass the exam, send us a picture. We want you on our wall of fame. There is a book loaner program I explained in one of the closing comments. And on that note, and again, sorry to rush our ending, but we really do appreciate your participation. We've had some of the most fabulous presenters, and again, experts. You also are experts in your field. Remember to take the competencies grid, the opportunity in the ACHE site to understand where your strengths and weaknesses are. And good luck. And we really do want to hear back from you.
And also remember, if you need people to be references on your application, make sure you include any of us. Hit us up on LinkedIn or whatever, and fingers crossed for all of you. Good luck with everything.
And here's my email address to let me know if you don't want to be on that list. I will probably be like another week or so before we get it out. Or actually, probably sooner than that, because Satya is going to be sending all this out to everybody. Thank you all. Thank you, Navi. You were great.
Thanks, Nora. Thanks, Rick.
Thank you, Debbie. I guess it's just the two of us.
Oh, did Navi drop off?
Yes, you did. Yeah.
Oh, darn.
Yeah.
I wanted to debrief with her.
Yeah.
She's fabulous.
She's really good.
Fabulous.
And I felt bad that we were rushing her, but I mean, Sachin went like 25 minutes over.
I know. And I know that was
I wanted the thing the Supreme Court has, you know, where you have a yellow light that comes on when you have 5 minutes and then a red light and it shuts you off. You can't talk at all. And the text doesn't do real well for signaling him while he's talking of speed it up or shut up.
You know what I'll do? I can start doing this.
Maybe, yeah, like hold up a thing saying 5 minutes or something, or
Yeah, even if other people are seeing it, you know.
Yeah, it's yeah.
Okay.
This might help us keep on track that way. I just had the thought as Navi was reading the objectives again. If I keep saying that's a total waste of our time because they can read it, but I think the question I was trying to ask last week and I wanted to ask this week of, so how would you organize it? So, you know, what are the key things? Like Navi mentioned, okay, know each of these techniques. Okay, would be a good hint, and we could ask our experts for just a couple of bullets of what's the best way to study for this and what resources do you recommend?
That one.
Yeah.
Because we already are giving them the highlights in the rework.
Yeah, that there's just no need to give them
right and say, so we'll ask the presenters, give us 2 bullet points out of all of that, you know, summarize
2 or 3
all of that into 2 bullet points.
No, not even the bullet points on what are the key points, but how would you organize to study, right? In the same way that I do the thing with put it into the groups of laws.
Yeah.
Something like that, you know, that whatever they come up with, I mean, we might get different things from different people. You know, James talked about, you know, knowing the ratios, the categories of ratios, things like that.
That's the key.
If we can ask each of them, just give us, you know, 3, whatever, you know, hints to study, to organize yourself. And then, you know, for where the well-managed healthcare organization doesn't fit or doesn't cover stuff as well, what is a good source if this is an area you need help? So finance, quality, et cetera, the ones that people need help on.
Okay, I like it.
I think it'll tighten it up and it'll give more useful stuff than just reading the ACHE objectives.
You're right. You're right. And again, it's duplicative.
Yeah,
you know,
so
we're giving it to them and then you're hearing your recordings and it's like,
yeah, well, I mean, it's how do we make the best use of the time? So yeah, we're done. Yeah.
Again, I think I'm gonna have a debrief on Thursday, I wonder.
I think
if we're not,
we should at some point, but yeah.
Yeah.
Michael just seems like he's been kind of out of it the last couple of weeks. So, you know, did he say he's dropping off or just doesn't want to be chair anymore?
I believe he's dropping off.
Yeah.
But we don't have a replacement yet.
Yeah. And,
you know, and I need to drop off, but
no,
I don't want to without.
Yeah.
I know, right?
No. I cannot drop off because I really want to get that 3rd level of volunteer thing. I think I've got like another 10 years of doing this to get that. So
okay.
So I guess I'm going to stick around till I get it.
But you know, Yeah, I keep telling Jim this will be, my last session, my last series, and then it's like, but no, I get too much of a kick
Well, I
out of
get a
getting them
kick on
down.
this. I get a kick on the Saturday mornings. The Thursday evenings, I want to scream sometimes. If I don't understand why we're doing as much as we do.
Well, did you, I thought last Thursday was good because it was short,
Yeah.
boom, boom.
Yeah, I mean, all it is okay, do we know for sure who's doing what? And here's our time. And
Yeah.
I mean, we need one at the beginning of who's going to do what area,
Mhm.
but just, confirm all the administrative assignments and the timing, it's like a meeting that can be an email. Someone said,
And I did think it helped really to just have everything on the Google Drive. And
Yeah.
I think we lost track of who was going to get rid of that one slide with the event that just
oh,
passed. But
yeah.
it was good to keep it because you brought up,
I
look
faked
out.
I faked my way through it. Yeah.
But this is this is why you're you. I love
No,
it.
it's just 30 years of teaching,
You're natural.
Well, no, I'm not a natural. I've been doing it that, things go wrong and I don't let them bug me the way they used to when I was starting out. If something went wrong, I was in big trouble. And now I can just fake my way through it so that the students probably have no idea anything happened.
I hope Navi didn't feel like we
I'll touch bases with her.
okay. It was not an intent.
So
She was
Stan had an
fabulous.
operation yesterday that he said down in San Francisco, he said went quickly and he was home last night. But next Thursday, he's having an operation that's supposed to go 5 hours or so. So
Yeah.
he's a spinal cord or spinal cancer survivor, not spinal cord, but spinal cancer, and therefore has tons of chronic pain issues. And a year or so ago, he got one of those implants. So I don't know if that's what he's doing or
The
what.
pump, like the pain pump thing.
Yeah. He doesn't always give me details of what's going on with him, which
Wow.
but yeah, I've always wanted to see his torso x-ray. He's talked about it, of all the metal rebar going through and supporting it.
Hey, so did you stop recording by any chance?
I didn't.
Oh.